We are live.
Great. Welcome to the House Healthcare Committee, everyone. It is Tuesday, April 4th. We have before us S37, an act relating to access to legally protected healthcare activity and regulation of healthcare providers. Before we start the walkthrough, there is one agenda item that we'll do at the very end of today. So H282, which is the Psych Pact Compact that was passed out of here. It's on the floor tomorrow. Ways and Means is actually going to make an amendment on the floor to, I forget the actual terminology, but remove the amendment, take leave of the amendment. So it'll just be our bill and then the appropriations amendment, which is just approval of our bill, and Ways and Means approval of our bill. But because of that, we need to change the effective date. So OPR had wanted it to start July 1st, 2024, and right now in the bill it's 2023. So Jen has drafted a quick amendment that we will vote on quickly at the end of the day so that we're ready for the floor tomorrow. So just don't rush out of here when we're done with this testimony. So we have several witnesses today, but we are first going to start with Legislative Counsel. Thank you for coming and walking us through the bill.
Welcome. Good afternoon, everyone. For the record, Amber Nabberjilly, Legislative Counsel. Before we start going through, this is a lengthy bill. So before I start the formal walkthrough, I'm just going to give you sort of a one-sentence overview of all of the topics that are covered by the bill so that you know what to expect. So in the first section, you're going to see some definitions. These are definitions that will run through all of the sections of the bill, and these are the definitions that have also been in H89, the bill relating to judiciary aspects of legally protected healthcare. After the definitions section, there's a section that would prohibit a medical malpractice insurer from adjusting a healthcare provider's risk classification or premium charges based on the healthcare providing legally protected healthcare activity in certain circumstances. Then there are a few sections that will require that health insurance plans and Medicaid cover gender-affirming healthcare services and abortion-related services. Then there are a couple sections that will prohibit a healthcare provider from being subject to professional disciplinary action for providing or assisting in the provision of legally protected healthcare. Legally protected healthcare activity, that's another defined term within that definition sections. It does include reproductive healthcare services as well as the gender affirming healthcare services. Then you have another section that will establish a new unfair and deceptive act in commerce regarding pregnancy centers to prohibit false and misleading advertising about their services. Then a section that requires the Green Mountain Care Board and the Agency of Human Services to report on access to reproductive and gender-affirming healthcare services as part of their ongoing projects and analyses. There are a couple sections concerning interstate compacts. These sections would first require that the Office of Professional Regulations submit a report regarding the state's participation in interstate compacts, current and future, and then also directing Vermont's compact delegates to support protections for healthcare providers. Then there are a couple sections around emergency contraception, allowing pharmacists to prescribe emergency contraception and permit pharmacies and colleges and universities to make non-prescription emergency contraception and other contraceptives available by vending machines. There are a couple sections concerning Vermont's public institutions of higher education, specifically the Vermont State Colleges and UVM. It would require those institutions to report on their students' access to reproductive and gender-affirming healthcare services. And there's a last section that would limit the circumstances under which covered entities and business associates may disclose information regarding legally protected healthcare activity. That is the very high level of what you will see in the bill. Now I will share my screen so that everyone can see the bill language.
And everyone has a copy, a paper copy that once went around the table. Okay.
So here I have S37, an act relating to access to legally protected healthcare activity and regulation of healthcare providers. This is the as passed by Senate version. First, in section 1, you have definitions. This would add a new section 150 into Title 1. Section 150, legally protected healthcare activity, subsection A. Gender affirming healthcare services means all supplies, care, and services of a medical, behavioral health, mental health, surgical, psychiatric, therapeutic, diagnostic, preventative, rehabilitative, or supportive nature relating to the treatment of gender dysphoria and gender incongruence. Gender affirming healthcare services does not include conversion therapy as defined in Title 18, Section 8351. Subsection B is the definition of legally protected healthcare activity, which first means the exercise and enjoyment or attempted exercise and enjoyment by any person of rights to reproductive healthcare services or gender affirming healthcare services secured by this state. It also means any act or omission undertaken to aid or encourage or attempt to aid or encourage any person in the exercise and enjoyment or attempted exercise and enjoyment of rights to reproductive healthcare services or gender affirming healthcare services secured by this state, provided that the provision of such healthcare service by a person duly licensed under the laws of the state and physically present in the state shall be legally protected if the service is permitted under the laws of the state, regardless of the patient's location. These are protections for Vermont providers who are licensed in the state and who are physically present in the state, regardless of whether their patient is in Vermont or outside of Vermont.
We're going to hold questions. I just said the same thing to Mari. She's writing hers down. So let's get through at least the definitions first.
It's a definition question. So.
Yep. So write it down.
Yep, I got it.
Or C, the provision, issuance, or use of, or enrollment in insurance or other health coverage for reproductive healthcare services or gender affirming healthcare services that are legal in this state, or to any act to aid or encourage or attempt to aid or encourage any person in the provision, issuance, or use of, or enrollment in insurance or other health coverage for those services, regardless of the location of the insured or individual seeking insurance or health coverage, if the insurance or coverage is permitted under the laws of this state. Now we come to some exceptions. So except as provided in the next subdivision, these protections are applicable to, the protections applicable to legally protected healthcare activity shall not apply to a lawsuit, judgment, or civil, criminal, or administrative action that is based on conduct for which an action would exist under the laws of this state, if the course of conduct that forms the basis for liability had occurred entirely in the state. So if services are provided in Vermont and they meet all of the legal requirements in Vermont, I'm sure I'm explaining this correctly. If the purpose of this exception is so that if someone were to receive services that are legal in Vermont, but are illegal in another state provided by a Vermont, in this example, by telehealth, right? If a Vermont provider who's licensed here provides services that are illegal in another state, but are legal in Vermont, the protections apply. However, if the services are provided in a way out of state that are not only illegal in that state, but also would not meet the standards of Vermont laws, these protections do not apply. So it's a protection against things like negligent services or other ways of providing services that would either not meet professional standards of practice in Vermont or would not meet legal standards in Vermont. This would not allow those to be covered. This would not allow the protections to cover those situations. We want to preserve the ability for people to pursue administrative or civil or criminal actions if those services would not be legal or meet professional standards in Vermont. The exception to that exception is in subdivision 3. So notwithstanding subdivision 2 of this subsection, the provision of a healthcare service by a person duly licensed under the laws of the state, physically present in the state, shall be legally protected if the service is permitted under the laws of this state, regardless of the patient's location or whether the healthcare provider is licensed in the state where the patient is located at the time the service is rendered. So in Vermont, for someone to provide telehealth services, they need to be licensed to provide telehealth services. We're saying in this section that while normally there might be the person might be subject to discipline, that if a Vermont licensed provider provides telehealth services to someone out of state, in a state where those services are not legal, the fact that the provider is not licensed to provide telehealth in that other state would not eliminate their ability to be protected under this bill.
You said it again.
Over that a couple.
Yeah.
So I'm going to scroll back up. So in subdivision 2, we had just said that there are no protections if the provider's action would have resulted in liability in Vermont for their services, either because it didn't meet the national standard. In Vermont, we require people providing telehealth services to people in Vermont to be licensed to provide those services if someone is trying to provide services in Vermont from out of state. So because we have subdivision 2, that exception, if Vermont wants to protect Vermont providers who are providing services out of state, but without a license to provide telehealth services, and you'll hear reasons for why providers might want to provide services out of state without being licensed to do telehealth. If we want to continue to protect those, we need to make an exception to subdivision 2. Is that clear?
I'm not sure that's still clear for me. Hold on.
Can you tell me what page we're on again?
Yes, this is bottom of page 2 into page 3.
I read ahead and then I was like, oh.
So I could, yeah.
No. So the gist of it is that if you are doing a service that is legal in the state of Vermont and you're providing telehealth, even in a state in which for a patient who is in that state, but you're not licensed in that state, this allows the state of Vermont to protect you, the provider.
Yes.
It has
Okay.
nothing to do with whether or not they have a Vermont telehealth license. It's just as long as they're licensed in Vermont. Okay, that was my confusion.
Yeah.
The fact that in Vermont, we say you need to be licensed to provide the services where we require you to be licensed.
Right.
We're saying just because the other state requires you to have a telehealth license, we're not going to eliminate all the protections just because you don't have that telehealth license. So long as you're meeting all of the other legal standards and professional practice standards, just the licensure aspect isn't enough to lose all of the protections. It doesn't mean you might not still be liable for other circumstances which make you lose, but just the licensure aspect is not enough to lose the protections of this.
Is that going against some of the compacts and
We're gonna talk about, let's hold that question, because there is a whole compact section, so. Okay, let's finish the definitions and then we'll come back to questions.
Subsection C, reproductive healthcare services means all supplies, care, and services of a medical, behavioral health, mental health, surgical, psychiatric, therapeutic, diagnostic, preventative, rehabilitative, or supportive nature relating to pregnancy, contraception, assisted reproduction, pregnancy loss management, or the termination of a pregnancy.
So that's the definition of what reproductive healthcare services is. Okay. All right, Mari.
So, on that, in that section, line 4, section C, it's the same language as page 1, line 8, and gender affirming healthcare services. In both of those instances, does the word supplies include medications? Or should we specifically include the word medications? Like in statute, does supplies mean medication.
Or care.
There was not a question that came up, in the Senate. I don't know that we have a definition there. I would think that it would be included within services or care, but we can,
I think it'd be good to be really clear about that, especially with
The Bristol?
the MI.
Yeah.
Yes. Misoprostol.
The Bristol, yeah.
So if you can clarify that, Amran, in the future, and then we'll figure out how to do that. Great. Leslie?
I'm good.
Art?
I'm just wondering, bottom of page 1, Ameren B, the top of page 2. When we talk about patients located out of state, are we talking about Vermont residents out of state? Is that what that means?
it would be any patient out of state, whether they're a Vermont resident or not.
Okay, so they don't have to be a Vermont resident, it can be anybody.
Correct.
Okay, so this will allow us to give this stuff to anybody who is out of state.
You mean, so this is, the definition does not provide any requirements for care. It only explains the circumstances where the protections apply.
Okay, so, but can providers here market out of state and get out of state people and then be protected in states that are anti all this stuff?
This does not change someone's ability to do those. The provider would still be subject to all of the laws of the other states. This bill is for saying how Vermont will respond
Okay.
to someone doing those.
The reason I ask is I thought H89 Vermonters who are like in college and you kind of gave them the care. This sounds like it's beyond that.
So and I'm just going to comment on that. So the definitions in this bill will be aligned with the definitions in 889. So the two, no, H89, right?
Yes.
Those, no, I don't think, and I'm gonna, if someone else, if Jen or anyone wants to jump in, I don't think that was what happened. I think it wasn't connected to Vermonters only.
Okay.
And then these definitions will align with what's in H89.
They're exactly aligned?
Not right now. H89 in the Senate will be working on that.
Okay, so, all right, but these definitions are the ones we're gonna go by.
We are, I mean, obviously, this is where we are, right?
Yeah.
So,
Okay.
but this is what we have in front of us right now.
And that holds true with all these steps, all these definitions, that it's patients out of state, any patient out of state.
Yes.
Thank you.
Okay, so this is gonna be a long bill to get through, and we need to get through the walkthrough in order to move forward with the rest. So what I would like everyone to do is write down their questions as we go. What we're going to do after the walkthrough and through the whole week is we are taking this sections at a time. So like write down your question with the section number next to it. If we have time, we will come back and ask Cameron some of the questions, but if we don't, I want to make sure we get everyone in today that's on the schedule, so.
Mine is just a quick addendum for Ameren about my earlier question, and I mentioned misoprostol, but also there are gender affirming care medications that be important to include as well, or just be all inclusive and make sure.
We'll just have the word medications if it's not.
Pardon me for standing up,
No, you're
everybody.
That's fine.
There were some comments and questions that came up towards the end of this bill, making it through the Senate around, do these definitions or anything in this bill change how consent works for minors? Because there's a large conversation about gender affirming healthcare services provided to minors. So just so that you are aware of what our current legal requirements are, is that 18 is the legal age of consent in Vermont. So individuals under the age of 18 are minors under Vermont law. And so there are some specific exceptions, which I will cover very briefly, but generally a minor's parent or guardian must provide informed consent for the minor to undergo medical treatment or procedure. So in terms of this circumstances of minors receiving services in the context of gender affirming healthcare or reproductive healthcare, the exceptions presently under statute is that minors can give informed consent for medical treatment associated with rape, incest, or sexual abuse. Minors can give informed consent for outpatient mental health treatment, including psychotherapy and counseling services, but not prescription drugs. And can give informed consent to reproductive health care, including contraceptive devices, termination of pregnancy, prenatal delivery, or other pregnancy care. There are a couple other exceptions that are not to this bill. Those are what current consent laws are in Vermont related to minors. These definitions in this bill does not change any of that, but just so you're aware of the context for this bill when we talk about gender affirming healthcare services and reproductive healthcare.
Great, thank you. Write it down, sorry.
I just wanted to get a copy of that.
Okay, yes, we could work on that.
Right. So now we are moving into section 2, which is about concerning medical malpractice insurance for healthcare providers. So first, we're going to have adding some definitions into chapter 29, insurance trade practices. So you may recall during my very high level overview of the bill, the purpose of this section is to limit the circumstances under which a medical malpractice insurer can increase or adjust premiums for healthcare providers providing legally protected healthcare. So one of those circumstances concerns when the provider is subject to abusive litigation. So first, we're going to look at a new definition that's being added concerning abusive litigation. So this is litigation or other legal action to deter, prevent, sanction, or punish any person engaging in legally protected healthcare activity by filing or prosecuting any action in any other state where liability in whole or in part, directly or indirectly, is based on legally protected healthcare activity that occurred in this state, including any action in which liability is based on any theories of vicarious, joint, or several liability derived therefrom, or attempting to enforce any order or judgment issued in connection with any such action by any party to the action or any person acting on behalf of the party to the action. A lawsuit shall be considered to be based on conduct that occurred in this state if any part of any act or omission involved in the course of conduct that forms the basis for liability in a lawsuit occurs or is initiated in this state, whether or not such act or omission is alleged or included in any pleading or other filing in the lawsuit. And then it would also add the definition of legally protected healthcare activity that we just covered in section 1. So that is the definition for what you'll see now in the changes to section 4724, unfair methods of competition or unfair or deceptive acts or practices defined. So the following are defined as unfair methods of competition or unfair or deceptive acts or practices in the business of insurance. So now we're looking at subdivision 7, unfair discrimination, arbitrary underwriting action. So current law says making or permitting any unfair discrimination between insureds of the same class and equal risk in the rates charged for any contract of insurance or in the dividends or other benefits payable thereon or in any other of the terms and conditions of such contracts. And then we add this new section, subdivision F. This would prohibit insurers from discriminating against a healthcare provider as defined in Title 18, Section 9496, or adjusting or otherwise calculating a healthcare provider's risk classification or premiums on the basis that One, the healthcare provider provides or assists in the provision of legally protected healthcare activity that is unlawful in another state. Two, another state's laws create potential or actual liability for that activity. Three, abusive litigation against a provider concerning legally protected healthcare activity resulted in a claim, settlement, or judgment against the provider. Or four, the license of the provider has been disciplined in any way by another state based solely on the provider's provision of legally protected healthcare activity. And then in Romanet 2, for purposes of this subdivision, it shall not be unfairly discriminatory nor an arbitrary underwriting action against a healthcare provider if the risk classifications, premium charges, or other underwriting consideration are based on factors other than those listed in subdivision 1 of this subdivision F. So to back up briefly, we're talking about healthcare providers who have medical malpractice insurance. This prohibits the medical malpractice insurer from changing or adjusting their premiums or risk classification solely because that provider provides or assists in the provision of legally protected health care activity that is unlawful in another state. That another state's laws create potential or actual liability for that activity, regardless of the provider's activity. That the provider has been the subject of abusive litigation concerning their provision of legally protected healthcare activity, and it resulted in a claim, settlement, or judgment against the provider. Or that provider was disciplined by another state solely because that provider provided legally protected healthcare activity. And then lastly, just an explanation that the insurers may still adjust those premiums or other risk classifications for reasons other than those listed. Okay. That is the end of the medical malpractice insurance piece. Okay. So next, we're moving into insurance coverage. First, adding section 4088M to Title 8, coverage for gender affirming healthcare services. First, in subsection A, as used in this section, 1, gender affirming healthcare services has the same meaning as in Title 1, Section 150 that we covered at the beginning of the bill. 2, health insurance plan means Medicaid and any other public health care assistance program, any individual or group health insurance policy, any hospital or medical service corporation or health maintenance organization subscriber contract, or any other health benefit plan offered, issued, or renewed for any person in the state by a health insurer as defined in Title 18, Section 9402. And when we're talking about insurance here, remember, we're talking about only that slice of the insurance pie that the state is able to regulate, which is our small group in individual markets and our fully insured large group market. For purposes of this section, health insurance plan includes any health benefit plan offered or administered by the state or any subdivision or instrumentality of the state. Here we're talking about the Vermont State Employees Plan, right, as well as for the teachers. The term does not include benefit plans providing coverage for a specific disease or other limited benefit coverage, except that it includes any accident or sickness health plan. Subsection B is the coverage requirement. So first, a health insurance plan shall provide coverage for gender affirming healthcare services that A, are medically necessary and clinically appropriate for the individual's diagnosis or health condition, and B, are included in the state's essential health benefits benchmark plan. Subdivision 2, coverage provided pursuant to this section by Medicaid or any other public health care assistance program shall comply with all federal requirements imposed by the Centers for Medicare and Medicaid Services. 3, nothing in this section shall prohibit a health insurance plan from providing greater coverage for gender affirming healthcare services than is required under this section. And then subsection C, cost sharing. A health insurance plan shall not impose greater co-insurance, co-payment, deductible, or other cost sharing requirements for coverage of gender affirming healthcare services than apply to the diagnosis and treatment of any other physical or mental health condition, mental condition under the plan. Okay. Section 4 is coverage for abortion and abortion-related services. This would add a new section 4099E to Title 8. Subsection A, definitions. As used in this section, 1, Abortion means any medical treatment intended to induce the termination of or to terminate a clinically diagnosable pregnancy, except for the purpose of producing a live birth. 2, insurance plan means Medicaid and any other public health care assistance program, any individual or group health insurance policy, any hospital or medical service corporation or health maintenance or organization subscriber contract, or any other health benefit plan offered, issued, or renewed for any person in the state by a health insurer as defined in Title 18, Section 9402. For purposes of this section, a health insurance plan shall include any health benefit plan offered or administered by the state or any subdivision or instrumentality of the state. The term does not include benefit plans providing coverage for a specific disease or other limited benefit coverage, except that it shall include any accident and sickness health plan. And that is the same definition of health plan as in the previous section for gender affirming healthcare services. So subsection B, coverage. A health insurance plan shall provide coverage for abortion and abortion-related care. Subsection C, cost sharing. The coverage required by this section shall not be subject to any copayment, deductible, coinsurance, or other cost-sharing requirement or additional charge, except 1, to the extent such coverage would disqualify a high-deductible health plan from eligibility for a health savings account pursuant to 26 U.S.C. Section 223. So that's to comply with some federal requirements about when you can eliminate copayments, but still have you can eliminate copayments without affecting a high deductible health plans from being eligible for a health savings account. And then 2, this no cost sharing requirement would not apply to Medicaid. So for coverage provided by Medicaid.
Will you write down your question, please?
Okay.
Section 5 is a state plan amendment. The Agency of Human Services shall seek a state plan amendment from the Centers for Medicare and Medicaid Services or federal authorities if needed to allow Vermont's Medicaid program to provide coverage consistent with this act. So this is language to accompany the previous 2 sections. So there are some circumstances where Medicaid has to seek approval from the Centers for Medicaid and Medicare in order to include services within their plan, the Medicaid state plan. And this directs the agency to seek that approval if they need to provide those services. Provide coverage for those services. Now shifting gears over into the professional regulation context. Section 6 concerns those professions that are regulated by the Office of Professional Regulation. There are also some healthcare providers that fall under the purview of the Board of Medical Practice. So Section 6 concerns those professions from OPR, and then Section 7 will be those professions that are covered by the Board of Medical Practice. So subsection F1, healthcare providers, in the context of unprofessional conduct, notwithstanding subsection E of this section or any other law to the contrary, no healthcare provider shall be subject to professional disciplinary action by a board or the director of OPR in this instance, nor shall a board or the director take adverse action on an application for certification, registration, or licensure of a qualified healthcare provider based solely on A, the healthcare provider providing or assisting in the provision of legally protected healthcare activity, or B, a criminal or civil action or disciplinary action against the healthcare provider by a licensing board of another state based solely on the provider providing or assisting in the provision of legally protected healthcare activity. Subdivision 2 adds some definitions. First, healthcare provider has the same meaning as in Title 18, Section 9496. Legally protected healthcare activity has the same meaning as the definition we saw in Section 1. And so then you have mirroring language here in Section 7. I won't go through it line by line since it is the only words that we changed really are talking about the board as opposed to a board or the director. Here we just mean the Board of Medical Practice. But otherwise, the language is the same. Okay. Right. Section 8 is concerning pregnancy centers. We're in Title 9, Chapter 63, which is consumer protection, adding a new subchapter 11.
So I'm going to suggest that we skip the findings for right now and let's come back to those when we have some time.
Certainly.
That's okay.
Yes.
I promise we'll come back.
So we're adding subchapter 11, Pregnancy Services Center Fraud, adding a new section 2491, which has findings and legislative intent language. That's moving from page 11 into page 12. And then through onto page 13. And then you'll see a new definition section, or 2492 on page 13.
Can you actually do the intent? Sorry. Let's just right above it, do the
Sure.
intent.
Yes.
That'd be great.
Subsection B, intent. It is the intent of the General Assembly to ensure that the public is provided with accurate, factual information about the types of healthcare services that are available to pregnant individuals in this state. The General Assembly respects the constitutionally protected right of each individual to personal reproductive autonomy, which includes the right to receive clear, honest, and non-misleading information about the individual's options and to make informed, voluntary choices after considering all relevant information. 2, the General Assembly respects the right of limited services pregnancy centers to counsel individuals against abortion, and nothing in the subchapter should be construed to regulate, limit, or curtail such advocacy. Section 2492, definitions. First, we have a definition of abortion, any medical treatment intended to induce the termination of or to terminate a clinically diagnosable pregnancy, except for the purpose of producing a live birth. 2, client means an individual who is inquiring about or seeking services at a pregnancy services center. Emergency contraception means any drug approved by the U.S. Food and Drug Administration as a contraceptive method for use after sexual intercourse, whether provided over the counter or by prescription. Health information means any oral or written information in any form or medium that relates to health insurance or the past, present, or future physical or mental health or condition of a client. Limited Services Pregnancy Center means a pregnancy services center that does not directly provide or provide referrals to clients for abortions or emergency contraception. Pregnancy Services Center means a facility, including a mobile facility, where the primary purpose is to provide services to individuals who are or may be pregnant and that either offers obstetric ultrasounds, obstetric sonograms, or prenatal care to pregnant individuals or has the appearance of a medical facility. A pregnancy services center has the appearance of a medical facility if 2 or more of the following factors are present. A, the center offers pregnancy testing or pregnancy diagnosis or both. The center has staff or volunteers who wear medical attire or uniforms. The center contains 1 or more examination tables. The center contains a private or semi-private room or area containing medical supplies or medical instruments. The center has staff or volunteers who collect health information from clients. And the center is located on the same premises as a state licensed medical facility or provider or shares facility space with a state licensed medical provider. Premises means land and improvements or appurtenances or any part thereof. So with those definitions in mind, Section 2493 creates a new unfair and deceptive act. Subsection A, it is an unfair and deceptive act and practice of commerce and a violation of Section 2453 of this title for any limited services pregnancy center to disseminate or cause to be disseminated to the public any advertising about the services or proposed services performed at that center is untrue or clearly designed to mislead the public about the nature of services provided. Advertising includes representations made directly to consumers, marketing practices, communication in any print medium such as newspapers, magazines, mailers, or handouts, and any broadcast medium such as television or radio, telephone marketing, or advertising over the internet such as through websites and web ads. For the purposes of this chapter, advertising or the provision of services by a limited services pregnancy center is an act in commerce. Subsection B, the medical director of a pregnancy services center or the individual charged with supervising healthcare services provided by center staff or volunteers at a pregnancy services center shall be responsible legally and professionally for the activities of staff and volunteers performing duties for and on behalf of the pregnancy services center. The medical director or individual shall ensure that the staff of the pregnancy services center, including the medical director or individual, and any volunteers providing healthcare services, maintain a level of supervision, training, and practice consistent with legal requirements established under Vermont law, including those set forth in Title 26 and professional standards of practice. Failure to conduct or to ensure that healthcare services are conducted in accordance with state law and professional standards of practice may constitute unprofessional conduct under Title III, Section 129A, which is for professions under OPR's jurisdiction, and 26 BSA 1354, which is for professions under the Board of Medical Practice's jurisdiction. The Attorney General, I'm now in subsection C. The Attorney General has the same authority to make rules, conduct civil investigations, and bring civil actions with respect to violations of subsection A as provided under subchapter 1 of this chapter. So this is saying as a violation of the consumer protection chapter. We're now switching gears again to talk about interstate compacts. Section 9, subsection A, and this is concerning access to reproductive health and gender affirming care services and some ongoing reporting and analyses that are already happening at the state. So subsection A, the Agency of Human Services shall include access to reproductive healthcare services and access to gender affirming healthcare services as indicators for equitable access to healthcare in its community profiles of health and well-being analysis. And then subsection B on page 17, the Green Mountain Care Board shall include reproductive healthcare service and gender affirming healthcare service needs in the health resource allocation plan analysis under Title 18, Section 9405. Section 10 is a report requirement for the Office of Professional Regulation in consultation with the Board of Medical Practice. So on or before November 1st, 2024, OPR, in consultation with the Board of Medical Practice, shall submit a report to the House Committee on Healthcare and the Senate Committee on Health and Welfare with findings and recommendations for legislative action to address any concerns regarding the state's participation or contemplated participation in interstate licensure compacts as a result of the provisions of this act, including the state's participation in the Nurse Licensure Compact and the Interstate Medical Licensure Compact, which are the two healthcare provider compacts that Vermont is currently participating in. Section 10A, also relating to interstate compacts. This would add a new subchapter 2 in Chapter 56 of Title 26, which is the Occupations and Professions title. Interstate compacts, healthcare provider compacts. Section 3071, healthcare provider compacts, direction to Vermont representatives. As you may recall from going over the recent compacts, each compact has a delegate or representative. Vermont has a representative or delegate for the commission for each of the compacts. So this is direction to those Vermont representatives. Subsection A, the General Assembly finds that a state's prohibition of or limitation on the provision of gender affirming healthcare services or reproductive healthcare services or both, as defined in Title I, Section 150, prohibits healthcare providers from following healthcare best practices and is a failure on the part of the state to provide healthcare services that are medically necessary and clinically appropriate for its residents. Therefore, it is the General Assembly's intent to protect the ability of professionals licensed, certified, or registered in Vermont and applicants from other member states seeking to practice a profession in Vermont pursuant to an interstate compact or agreement to have the benefit of compacts and agreements while at the same time engaging in providing or otherwise facilitating, personally or professionally, gender affirming healthcare and reproductive healthcare services. Subsection B, Vermont's representative or delegate for an interstate compact or agreement related to healthcare shall seek an amendment or exception to the compact or agreement language, rules, or bylaws as necessary, so that if a licensee is disciplined by another state solely for providing or assisting in the provision of gender affirming healthcare services or reproductive healthcare services that will be legal and meet professional standards of care if provided in Vermont, the compact or agreement does not require that Vermont take professional disciplinary action against the licensee. Now I'm going to turn this over to Jen Carby.
So let's take a minute.
Oh, you're going to do questions for me?
Well, yeah, I guess let's see if there's any questions for Ameren. Murray?
A related question, page 5, line 3 talks about discriminating healthcare professionals about premiums, and then related on page 7, page 8, line 12, where it gets into individuals, not healthcare professionals, will be protected as far as out-of-pocket costs. Is there anywhere where individuals are protected against premium increases? So that it says there's a protection for healthcare providers to not put them in a different cost risk spot.
For medical malpractice.
Right.
And that there be premium protections, but only out-of-pocket protections for individuals, not protections against premium increases.
The premiums currently go through for the small group and individual markets, go through the premium process, approval process through the Green Mountain Care Board each year. So to say that the Green Mountain Care Board has to ensure that premiums meet all legal requirements. And one of those requirements is that there is community rating in Vermont for those plans, that you can't differentiate, just like you can't differentiate between someone's age or whether they smoke.
Got it.
You would not be able to here either.
Makes sense. Thank you.
Melissa?
So on page 7, well, sort of 6 and 7, coverage, health insurance coverage of gender affirming care. It says include,
What row?
oh, I'm sorry. So page 7, basically line 1, the and. I guess I'm going back to the definition of gender affirming care, which includes surgery. Does this require that insurances cover surgery, or is it because of the and included in the state's benchmark plan? Because surgery is not covered in the benchmark plan? Is this section requiring that they cover surgical?
So it's requiring that the plan cover any medically necessary and clinically appropriate care for the individual's diagnosis or health condition, and are included in the state's essential health benefits benchmark plan. The benchmark plan, this actually might be a good question for the Department of Financial Regulation about how detailed the essential health benefits benchmark plan goes into the type of services that are covered. I do believe that it got down into that level of surgical versus not surgical care, but I think that would be a good question for the Department of Financial Regulation.
I had a similar question about what exactly does our essential health benefits cover.
And just to clarify, that piece is not in the abortion care that follows in the next section. Am I correct? So that is missing.
You are correct. It is just in the gender affirming healthcare.
All right.
So did we say it was medical surgery also?
No, we will talk to
Clarify.
DFR. Yeah, we'll talk to DFR. Art?
Page 8, I want to try to figure out what insurance coverage is affected here, like health insurance plan shall include any health benefit plan offered or administered by the state or any subdivision or instrumentality of the state. Mm-hmm. Does that mean every health plan in the state must have this in it? Or you said this was just for the state portion of insurance. Some plans don't have to have this?
Correct. All of the self-insured employer-sponsored plans, the state cannot regulate them because we're preempted by federal law.
Okay, so they do not have to include this type of.
This goes back to, remember, we always have this conversation when it's the pie graph and the one little sliver that we can control.
Can we remember the percentage we can control?
It's about 75,000 people, I think. Is that right? Plus,
Right, so the small group and individual market is usually somewhere between 70 and 80,000, depending on the year. Then you have the large group fully insured market, which is usually somewhere between 15 and 20,000.
yeah.
And then you would have the state employees health plan.
And we're going to have the insurance companies come in. So let's tag that question. for them.
Okay, I'd like to see a percentage that we're covering with all of this stuff.
Okay. Let's, just if you can remember to jot that down, and when the insurance companies come in, we'll chat with them. Topper?
On page 2, C, big C, line 7. Could you explain what, when it gets to the word or, which is after state, can you explain that? What that means?
I'm sorry, could you repeat the question? You're looking at subdivision C.
Page 2,
Yes,
line 7.
line 7, yeah.
Talks about gender affirming healthcare services that are legal in the state.
Yep.
Or any act to aid or encourage or attempt to aid or encourage any person in the provision, insurance or use of enrollment in. What does that mean?
So the first section is just for covers, health insurers, employers who are providing a self-insured plan for their employees, people who are using insurance or attempting to enroll in insurance, saying that the coverage applies, that the protections apply for those insurers or for those employers who are providing the insurance, or for someone who's seeking insurance or attempting to get insurance for that covers reproductive healthcare services or gender affirming healthcare services that are legal in the state. And then it also covers any act that someone does, say someone tries to help you get insurance that would cover your reproductive healthcare services or gender affirming healthcare services that you want. So the first is to people who are directly providing that or directly trying to access the insurance. And then the second part is for anyone who's trying to help someone get insurance or use insurance or who provides insurance or other health coverage.
Yeah.
So long as the coverage itself would be legal in this state.
Thank you.
All right. So if you have other questions, let's write them down and let's switch so Jen can pick up the rest. Thank you, Ameren.
You're welcome. Jen, do you got log off? Log on? You're welcome to just use my.
Search the rest of it. Right. Good afternoon, Jen Carvey, Legislative Counsel. We'll pick up with section 11. We're into topics of emergency contraception. And this is first adding a definition. We're in the chapter of the statutes on pharmacy, the practice of pharmacy and pharmacists. And this would add a definition of emergency contraception, which means any drug approved by the U.S. Food and Drug Administration as a contraceptive method for use after sexual intercourse, whether provided over the counter or by prescription. There are some available over the counter and some available by prescription. Then in section 26 VSA, section 2023, if you remember when we were working on the COVID flexibility extension bill, we looked at the authority for pharmacists to do various clinical prescribing activities. And that, since we're looking at the COVID tests,
19.
but here we are on page 20, adding emergency contraception to the list of items, medications that a pharmacist may prescribe.
On the screen there.
Oh, thank you. And I did not
Okay,
scroll.
that's
Thank you.
confusing me.
Yes, I'm just looking at the paper. I should just look on here, frankly. Thanks very much. All right, so we were on section 11, page 19. There's that definition of emergency contraception. And then we're adding to the list of what a pharmacist may prescribe in accordance with a state protocol approved by the Commissioner of Health after consultation with the Director of OPR and the Board of Pharmacy and ability for public comment. This adds emergency contraception. And then section 11A adds a new section in this chapter on pharmacies and pharmacists on emergency contraception and vending machines. And this would authorize a retail or institutional drug outlet licensed under this chapter. So that's like a retail pharmacy or a pharmacy at this part of an institution, a hospital, or a post-secondary school as defined in and subject to 16 VSA section 176. So that's private and public, may make over-the-counter emergency contraception and other non-prescription drugs or articles for the prevention of pregnancy or contraception available through a vending machine or similar device. And the language would allow the Board of Pharmacy to adopt rules to regulate the location, operation, utilization, and oversight of the vending machines and similar devices in a manner that balances consumer access with appropriate safeguards for theft prevention and safety. Then we get into other language on higher education. Would add a new chapter in Title 16 on access to reproductive and gender affirming healthcare services. Title 16 is the education title. So it starts by adding definitions of gender affirming healthcare readiness, which means each institution's preparedness to provide gender affirming healthcare services to students or assist them in obtaining gender affirming healthcare services, including having in place equipment, protocols, patient educational materials, informational websites, and training for staff, provided, however, that gender affirming healthcare readiness may include the provision of gender affirming healthcare services. Gender affirming healthcare services has the same definition that Amran went over with you in section 1. Institution means the University of Vermont or a college in the Vermont State College system. Medication abortion means an abortion provided by medication techniques. Reproductive healthcare services has the same meaning, again, as in section 1 of this act, and includes medication abortion. Reproductive healthcare readiness means each institution's preparedness to provide reproductive healthcare services to students or assist them in obtaining those services, including having in place equipment, protocols, patient educational materials, informational websites, and training for staff, provided, however, that reproductive healthcare readiness may include the provision of reproductive healthcare services. And telehealth has the same meaning as in our telehealth registration and licensure. Section 2502 requires each institution, so those were the public institutions of higher education, to report to the Agency of Human Services annually by November 1st on the current status of its gender affirming healthcare and reproductive healthcare readiness, including whether the institution has an operational health center on campus, whether the institution employs healthcare providers on campus, the types of gender affirming healthcare services and reproductive healthcare services that the institution offers to its students on campus, and the supports that the institution provides to students who receive those services. The institution's efforts to assist students with obtaining gender affirming healthcare services and reproductive healthcare services from licensed healthcare professionals through telehealth. The institution's proximity to a hospital, clinic, or other facility that provides gender affirming healthcare services or reproductive healthcare services, or both, that are not available to students on campus. The referral information that the institution provides regarding facilities that offer gender affirming healthcare services and reproductive healthcare services that are not available to students on campus, including information regarding the scope of the services that are available at each such facility, and the availability, convenience, and cost of public transportation between the institution and the closest facility that provides gender affirming healthcare services or reproductive healthcare services, or both, and whether the institution provides transportation. So by January 31st of each year, the Agency of Human Services will compile those materials submitted to it by the institutions and report to the committees of jurisdiction, including this committee, on the status of gender affirming healthcare and reproductive healthcare readiness at Vermont's institutions. So that's section 12. Section 13 is the timing of the first reports, requiring each institution to submit its first report on the status of its gender affirming healthcare and reproductive healthcare readiness to the Agency of Human Services by November 1st of this year, with the agency providing its first legislative report by January 31st of next year. Section 14 deals with prohibitions on disclosure of protected health information. And this amends an existing statute on disclosure of protected health information and the prohibitions on it. So this starts first by adding a couple of definitions. One of them, you'll see a few definitions, both new and existing, that reference 45 CFR section 160.103, and that's dealing with HIPAA, the Health Insurance Portability and Accountability Act of 1996, which is federal law, is the federal health privacy law. So it adds a definition of business associate, adds a definition of legally protected healthcare activity, again, referring back to that section 1 definition, and then just a couple of cleanup changes to the other definitions. Then in the existing law, this would add not only that a covered entity, but also a business associate. So this is somebody who is affiliated with the workflow of the covered entity. Covered entities are those that are covered by HIPAA. Business associates might be a vendor or the health information exchange that transmits data from one place to another, but is not itself a covered entity because it's not providing services. So a covered entity or business associate shall not disclose protected health information. This is under current law, unless the disclosure is permitted under HIPAA. But then we have new language in subsection C that says, in order to protect patients and providers who engage in legally protected healthcare activity, a covered entity or business associate shall not disclose protected health information related to a legally protected healthcare activity for use in a civil or criminal action, a proceeding preliminary to a civil or criminal action, or a probate, legislative, or administrative proceeding, unless the disclosure meets one or more of the following conditions. And I'll run through these, but just to say at the outset, under existing law, we say a covered entity cannot disclose protected health information unless it's permitted under HIPAA. There are certain instances under HIPAA where disclosure is permitted, but there might be reasons why, in this case, the state would want to prohibit that disclosure, even though HIPAA would permit it. That's what we're really looking at here. So in order to protect patients and providers engaging in legally protected healthcare activity, covered entity or business associate shall not disclose protected health information related to legally protected healthcare activity for use in one of these scenarios unless the disclosure meets one or more of the following conditions. So first, the disclosure is authorized by the patient or the patient's conservator, guardian, or other authorized legal representative. So the patient or their representative can authorize disclosure. Or the disclosure is specifically required by federal law, Vermont law, or rules adopted by the Vermont Supreme Court. Third, the disclosure is ordered by a court of competent jurisdiction pursuant to federal law, Vermont law, or rules adopted by the Vermont Supreme Court. And an order compelling disclosure under this subdivision must include the court's determination that good cause exists to require disclosure of the information related to legally protected healthcare activity. Fourth, the disclosure is to be made to a person designated by the covered entity or business associate and will be used solely in the defense of the covered entity or business associate against a claim that has been made or there is a reasonable belief will be made against the covered entity or business associate in a civil or criminal action, proceeding preliminary to a civil or criminal action, or a probate, legislative, or administrative proceeding. Or the disclosure is to Vermont's Board of Medical Practice or Office of Professional Regulation, as applicable, in connection with a bona fide investigation in Vermont of a licensed, certified, or registered healthcare provider. You can see, for the most part, these scenarios are really looking to keep the decision-making about disclosure either with the patient or with Vermont and Vermont's laws, or if we're required by federal law, but not allowing other states to compel disclosure around legally protected healthcare information. And then finally, we get to the effective dates. I don't know if you want to go through those or not. For the most part, they're not
No, we can hold off on those. So Art,
What we just went over, Jen,
Yes.
disclosure. How about a parent? Disclosure to a parent of the 14-year-old goes in and has this gender stuff done.
Well, as Amory went over, that wouldn't be happening without parental consent, because there is no exception in Vermont law for parental consent for gender affirming care.
Okay, so they would need
They
parental
would need the informed consent of the parent.
of the parent. Okay.
we will, Aaron, if you could just put something together on that you could post on our page, that would be great, consent wise. Great. Any other questions for Jen?
Yes.
I guess,
Go ahead, Ellen.
well, I'm not quite how to, now, abortions is a little different than the other, right?
Yep.
Okay, now, a 13-year-old getting abortion without the parent's consent, what about, how does the insurance play into that?
Insurance can get complicated as far as information. I don't think we have anything in this. I don't remember if there was anything that went into the other bill on insurance. I know we've done things in the past on explanations of benefits and allowing those to be sent. In instances of sexual assault, I know the victim can have an explanation of benefits sent elsewhere, but if it's not, in that case, there's a good chance, I think, that the explanation of benefits, if they use their insurance, would go to the family house. So it would, to wherever they're living. So there may be some disclosure, some learning.
The parents gonna find out.
The parents may or may not. There would be, under the bill, there'd be no cost sharing in most cases. So,
And so this will be a good question for the
Yeah.
insurance companies when they come in.
but yes, there are certainly
But there's nothing in this one that
complicated.
addresses
If
it.
there's anything in this bill, specifically address that.
I'm just thinking about things that are not covered under HIPAA, disclosures that HIPAA doesn't apply to. Is there anything in this that protects entities that aren't necessarily covered under HIPAA from then just being compelled to disclose to someone else?
I think in the other bill, there may be, in the judiciary, I'm looking at Jessica too, in the H89 bill, there is a lot looking at shielding compelled release of information or turning over of information. I have not focused on the non-HIPAA aspect. Can I phone a friend and say? If you know.
Jessica Barnard, Vermont Medical Society. The other bill does address disclosure of information in sort of the litigation context. So if there's summons or request for production or those sorts of requests for information, but not in a general sort of, would you send us this information sort of way outside of a court process? I think I might need to
Right.
know more of the examples that you're.
Right, I think the protections that are getting put in this bill and the other bill are really from compelled disclosure, and anything else presumably would not be required to be disclosed, so could be withheld, but
I mean, I'm just thinking about things like our own VCures that we have. So if you have an abortion and a claim goes to your insurance provider then sends that claim information to VCures, which is accessible by, frankly, the state of Vermont. So, I mean, imagine if there was like a Texas VCures or TCures or whatever they want to call it. So, I mean, if a claim went to Blue Cross Blue Shield of Texas from a provider in Vermont who provided telehealth services, and then Texas would then send that information to the state of Texas, who would then have that information. Because that's technically not HIPAA.
I guess I'm not clear if you're talking about information about a provider provided a service or a patient received a service. Because I think the everything with VCures is de-identified except at the.
Well, our VCures is, but who knows what Texas has, is what I'm saying. Could Texas compel Blue Cross Blue Shield to disclose the information that was given to them because a claim went in?
I have to defer that to, I think, Green Mountain Care Board and the insurers. I don't know.
Okay.
Yep. Art, and then Leslie, and then we're gonna go to Jessa. Hopefully in time.
Jen, is there anything in this bill, and there's a lot of verbiage in there, and I didn't hear it, I don't think, but I'd like to verify it, that protects the provider, the conscience protection of a provider or a part of a provider from legal action if they follow their conscience and don't participate in any of this?
There's nothing in the bill that requires a provider to deliver any of these services. So there's nothing in here that shields from liability because there's no requirement to provide, to deliver the service. I mean, short of abandoning a patient, there needs to be some sort of handoff if a provider's not going to see a patient that they have an established relationship with. But other than that, I'm not aware of anything in here or otherwise that would require a provider to perform these legally protected services. So it's protecting the performance of them, but it is not compelling the performance of them.
Okay. All right.
Leslie?
So I'm not sure these questions are for you, but we'll figure it out. I know you'll know. In the emergency contraceptive, I was just wondering how long the process takes, and we didn't go over dates, but it says September 1st, on such a date as Commissioner of Health approves the state protocol.
Mm-hmm.
I'm just wondering, what kind of process is that? And what if the commissioner doesn't approve it?
I don't know what they have been so far. They've been doing these for the last few years since the clinical prescribing provisions went in. So I think the Board of Pharmacy and or the Department of Health could give you a clearer sense of that. I don't know. Those dates have been in, I think, for a while, and nobody has said, oh, no, that seems insurmountable, but I don't know.
Okay, how that
I don't know
works.
if that just means nobody's really looked at them.
So on line 15, it says the board may adopt rules.
Yes.
What if they don't adopt rules?
Then they don't adopt rules. The Board of Pharmacy thought that they had the authority, that there's nothing in existing law that would prohibit retail or institutional drug outlets from putting out vending machines with emergency contraception in them now, so they did not want to be compelled to adopt rules. The language on post-secondary schools was added later, so I don't know if the Board of Pharmacy would have a different take on or feel more of a compulsion to adopt rules specifically because of that addition. So it might be something to ask them when they come in.
Okay.
But it had said shall, they asked for may.
Yeah, and I'm just wondering, why there. So that was my cue. And one more if I have. On page 22, I was just wondering, I'm sort of a little confused about what reproductive health care readiness means. This last side may include provisions, so that means you're not ready anymore, you're doing it. So I was just a little confused.
This idea originally came from a Massachusetts provision that required each public institution of higher education to have a readiness plan, which could sort of run the gamut of, we're not at all ready to, we are providing. And so this got it away from a plan, which some of the institutions seem to take as too much pressure to actually be delivering services they weren't equipped to deliver. But wanting to recognize that readiness to provide services can be actually providing services as well as kind of connecting patients or students, supporting students, transporting students.
Strange language, yeah. Okay.
Alan, yep.
Getting back to the abortion thing. So they don't need permission. So if a child comes from another state, they can get an abortion here.
Oh, we have
Maybe an exchange student or whatever, without parents' permission.
I'm using your computer.
It's okay.
So my understanding of the rationale or basis for the lack of an age limitation for abortion services is really the fundamental right language in our statutes. And so I don't think that they are, just wanted to pull them up before quoting from them.
In another state's one thing, but what about another country?
So the state of our statute says the state of Vermont recognizes the fundamental right of every individual to choose or refuse contraception or sterilization, and the fundamental right of every individual who becomes pregnant to choose to carry a pregnancy to term, to give birth to a child, or to have an abortion. So it sounds to me that if they're physically present in our state, Vermont recognizes their fundamental right.
And who would pay for that?
That would be up to the patient. I mean, that would be on the patient to pay for it. So if they have health coverage that is, applies in Vermont and provides coverage in Vermont for abortion services, then their insurance would. They might have to pay out of pocket. They might come up with a payment plan with the provider. But there's nothing in here that requires the state to pay for people coming in from elsewhere.
Great. Jen and Amron will be with us through a lot of the week, so we can always come back to any of these. Thank you for the walkthrough. Just hold on one second. Is Erica here? Okay, just, yeah. And so there's, we have 2 people testifying who have time limits. And so we're going to kind of juggle things around a little bit, but let's start with you. We might need to cut it and have you come back.
No problem. Happy to do that. Thank you. Good afternoon. Jessa Barnard. I am the Executive Director of the Vermont Medical Society, but I'm here on behalf of a number of organizations this afternoon. Also the Vermont Academy of Family Physicians, that's family practice physicians, the American Academy of Pediatrics Vermont chapter, and the Vermont Psychiatric Association, representing collectively around 3,000 physicians in Vermont. And our members provide primary care and specialty healthcare services in a range of settings, hospital-based practices, federally qualified health centers, and independent practices. And so between our members, they provide the full range of reproductive and gender-affirming healthcare services. A couple of points I would like to make in support of S37. We strongly support the findings of national medical associations that comprehensive reproductive healthcare services, including access to contraception and abortion, and the provision of gender-affirming care are the standard of care in medicine. And we know this question has come up not only in this bill, but on H89. And so I've referenced the leading clinical guidelines on both reproductive services from the American College of Obstetrics and Gynecology, as well as the guidelines from the Endocrine Society and the American Academy of Pediatrics on gender-affirming healthcare. Based on these evidence-based guidelines, the Vermont Medical Society has established policy positions supporting access to contraception, abortion, and gender-affirming care. You, I know, heard when you were considering H89, but I will just re-emphasize that such services are under attack in a number of other states, and that is why it's important for Vermont to protect these services. About half of U.S. states have already or are expected to enact abortion bans or other limits on the procedure, and more than a third of the 150,000 transgender youth aged 13 to 17 live in the 15 states that have restricted or banned access to best practice medical care for transgender youth. And I've linked also to some state policy trackers that show both the status of access to abortion services and also gender affirming care across the country. These laws vary widely. It's a little hard to sort of characterize them as one in one way, but they carry significant criminal penalties for healthcare professionals, including decades of prison time and tens of thousands of dollars in fines. So many, though not all, are targeted at the healthcare professional who then provides the services. There are some, but less so, that target the patient or those who help assist a patient in obtaining care. New forms of civil liability are also a reality, as exemplified by Texas's ban on abortion after 6 weeks, called SB 8, which allows any private citizen to sue anyone who performs or induces an abortion or aids and abets the performance of an abortion. So H89, which I know you took a look at and passed the House earlier this session, addresses ways to reduce healthcare professional, civil, and criminal liability. So that's really based on legal risk to individuals, the providers, and individuals who help somebody obtain care. But the risk of professional disciplinary action is likely even higher. Any individual in any state, this is the case with all licensing boards, can file a licensing complaint, thereby requiring a licensing body to investigate. So for example, in the state of Vermont, and I think this is universal for all licensing boards, if they receive a complaint, they have to investigate. And that means that the provider receives notice that a complaint has been filed and has to respond, which can be extremely stressful. They often have to obtain an attorney to help them respond to that complaint. Even if it's ultimately
found that there was no wrongdoing and is closed, that's not something that anyone takes lightly. We already have an example of the Attorney General in Indiana opening an investigation into a physician who performed an abortion on a minor, alleging that the physician did not properly file a child abuse complaint. So this was not an allegation that the actual services did not meet the standard of care, but really that they didn't properly file a complaint in another state. And that's being responded to, but certainly it's been very public and has very much impacted this physician's life and practice of medicine. The Florida Board of Medical Practice and Board of Osteopathic Medicine just last month finalized rules that define providing gender-affirming services to a minor as against the standard of care, leading to investigations or discipline in any instances of providing care against their policy, despite this being contrary to national and international best practice guidelines for care. So given tactics like the laws we're seeing states enact and the regulations we're seeing pass in various states or adopted in various states, legal risks and professional discipline now attach to healthcare professionals caring for patients who travel for care to Vermont or seek care via telemedicine. Based on this, last September, our board adopted a policy in support of what we're calling SHIELD laws that would protect healthcare professionals who provide reproductive or gender-affirming healthcare services. We worked closely with members of the Senate Health and Welfare Committee on the language in S37 and are very supportive of the language and approaches being proposed in the bill, and we ask for your committee to adopt them. I'll highlight a couple of the provisions of the bill that we think are particularly important to our members. We are in support of the language and the definitions around legally protected healthcare activity. We do think it's important, and I know all of the legislative council involved with the bill are making sure that they track the definitions between S37 and H89. And so we support that, and we support the definitions being inclusive of the broad range of evidence-based healthcare services needed, and also distinguishing clinical services from insurance coverage, just for clarity. We worked closely when the bill on this, I think, if I'm remembering correctly, it came about in H89, but clarifying the language that activity is not protected if it would be subject to legal or administrative action in this state. So that makes it clear that if a professional will be subject to discipline or other causes of action, those could still move forward if they did not meet Vermont law or standards of care. This is not meant to sort of shield from inappropriate or care that does not meet the standard of care. I know there were a number of questions, and I'll address briefly the exemption for telehealth without a license. I think this is an area that's gotten some discussion. I think it will have to be an area of education for healthcare providers who choose to offer such services without a license, because we want to be clear that that's not without a risk to that professional, that especially risk from either discipline or legal action from the state where they were providing the care to that patient, or where their patient was located. So I'll pick a state, if that patient is located in Texas and the providers here in Vermont provides telehealth services to a patient located in Texas, Texas may very well not agree that it's okay to practice telemedicine without a license in Texas. So they may take action against that professional. The issue is what can Vermont do to try to limit a Vermont licensing board or Vermont court for also taking action. But we want to make sure that clinicians don't think it's a full protection from any action that could take place, including within Texas. Texas Board of Medical Practice would almost certainly not agree with that policy decision. We support the section of the bill that does not allow a clinician's malpractice coverage to be dropped or rates to be increased for engaging in legally protected healthcare activity. OBGYNs already have some of the highest costs of malpractice coverage across the country, and for simply providing abortion services or making such services available, we agree that their malpractice rates should not be changed just because of that, and that there now may be new types of risks from other states or patients who have traveled from other states. We support the provisions that say that the clinician wouldn't be subject to disciplinary action solely based on providing legally protected healthcare activities. I think it is very worthwhile to further examine the implications of licensing compacts, and I heard that question come up. That adds a whole new twist to what actions our state or must take or could be taken against a clinician's license. Again, I think an opportunity for education to healthcare providers also to say, if you are providing these services, you may want to really look at the implications of participating in a compact, and maybe you make the decision it's, the legal risks are not worth it for you. Even if in general compacts are an excellent tool, we support compacts, but if you are providing high legal risk areas of care, you may want to think about participating in that compact. And we support protecting healthcare data from disclosure in legal proceedings. I want to note some things that the bill does not change, and they already came up in some of your questions this afternoon. They don't change or redefine in any way the standards of care, the standards of practice in Vermont, what healthcare services are protected by Vermont law, or which services minors can consent to. And so just want to thank you for taking up this bill. We support it moving forward. Happy to work with the committee as you get into more detail on any of the other sections.
Great, thank you. And so I hate to do this, but Dr. Gibson is here, and Dr. Gibson only has until 3:30. So we're going to switch, and Jessa will stick around for questions. Thank you, Jessa. Dr. Gibson, hi. Thank you for joining us.
Hi.
Can you hear us okay?
I can hear you. Can you hear me?
Yes, thank you. So I'm going to, since you have a lot of titles next to your name, I'm going to let you introduce yourself for the record, and then go through your testimony. And then if we have time, we'll have some questions, I'm sure.
Okay, sounds good. I'll go ahead and begin. So good afternoon, Chairperson Houghton and members of the House Health Care Committee. I'm grateful to all of you for the opportunity to be here today to show my support for S37, an act relating to legally protected healthcare activity and regulation of healthcare providers. My name is Dr. Erica Gibson, and I am a board certified pediatrician and adolescent medicine specialist. I currently serve as the division head of adolescent medicine at the University of Vermont Children's Hospital, where we run several adolescent medicine clinics, including the UVM Children's Hospital Transgender Youth Program. Today, I am speaking not only as a physician who provides direct care to youth and families, but also as an official representative of the University of Vermont Health Network, a member of the executive board of the Vermont chapter of the American Academy of Pediatrics, and as a member of the Vermont Medical Society. In April 2021, as attacks on youth gender care began to escalate in both public forums and state legislatures, the Vermont chapter of the American Academy of Pediatrics, UVM Children's Hospital, the Vermont Medical Society, and multiple other Vermont health organizations released a comprehensive memo that addressed the importance of the provision of thoughtful, comprehensive, developmentally appropriate, family-centered, gender-affirming healthcare, as recommended by evidence-based healthcare guidelines. That memo reiterates the fact that every major medical organization in the United States recognizes the medical necessity of gender-affirming care to improve the physical and mental health of gender-diverse people. We have submitted a copy of that memo again today, and we stand by all the information contained within. Unfortunately, as I speak to you here today, almost 2 years later, numerous other state legislatures have passed or are attempting to pass discriminatory laws that aim to prevent young people and families from accessing appropriate gender care, and also seek to penalize gender health care providers for providing this care. To quote a pediatric colleague of mine who testified against one of these bills in Ohio, quote, "These bills are an extreme rejection of safe and effective medical treatment for a vulnerable group of youth, and they enact barriers that would cause families irreversible harm and ultimately cost lives. In addition, these discriminatory laws in other states place my pediatric colleagues in the ethical dilemma of refusing evidence-based gender-affirming health care or face loss of medical license or criminal charges for providing this care. We're thankful that the state of Vermont has remained steadfast in support of gender diverse youth and their families and the care that we provide them. I would like to acknowledge the important joint resolution that was passed by the Vermont legislature in June 2022 to support transgender youth and their parents who seek essential medical care for the treatment of gender dysphoria. At this time, in a mounting crisis of child and adolescent mental health care, it is essential that care for gender diverse youth and their families is protected, and that the providers providing this evidence-based care are protected also. This bill will expand the ability to safely care for young people and families that seek evidence-based, legally protected healthcare in our state. I have been asked to briefly summarize the definition of gender-affirming care here in my testimony today. In addition to this statement, I respectfully submit a document entitled Supporting and Caring for Transgender Children, which was jointly written by the members of the American Academy of Pediatrics, the Human Rights Campaign Foundation, and the American College of Osteopathic Pediatricians. This document eloquently details the approach to gender affirmative care and also addresses the harm that may come from non-gender affirming care. In a gender-affirming care model, pediatric providers offer developmentally appropriate care that is oriented toward understanding and appreciating the youth's gender experience. As stated by the American Academy of Pediatrics, this means a strong, non-judgmental partnership with youth and their families that can facilitate exploration of complicated emotions and gender diverse expressions while allowing questions and concerns to be raised in a supportive environment. Gender affirmative care recommendations, as with all medical interventions offered by healthcare providers, are guided by the scientific evidence and ethical obligation to act in the best interest of patients. As stated by the American Medical Association, quote, a physician must tailor recommendations about specific interventions and timing of those interventions to each patient's unique circumstance, and must be sensitive to the child's clinical situation, short and long-term development. Pediatric gender care providers follow clinical practice guidelines from the Endocrine Society, an international organization of physicians and scientists who created these guidelines in collaboration with 6 other international professional medical organizations. In the case of gender affirming care, no medical interventions are mandated at any time, and no medications are offered to patients and families until puberty has started. Once puberty has begun, families might take the first step of initiating fully reversible medications, and then during later stages of care, might take the step of initiating partially reversible medications. It is important to understand that decisions to begin any medical interventions include a thorough discussion and education between a care team, a young person, and their parents or guardians. Parent or guardian consent is needed for a young person under 18 years of age to begin any medical interventions. And this legislation does nothing to change that requirement. In closing, we thank you for your commitment to the health and well-being of anyone seeking healthcare in Vermont. And on behalf of our patients and families and the multiple professional medical organizations that I represent here today, we respectfully ask the Vermont House to pass this bill.
Great, thank you. Thank you very much. And the document you referenced, did you send that to us? I know it's on it is in here? Okay.
It's on our website.
I see 2 documents, but I didn't see all that she said.
It's on the bottom of her testimony. Okay, thank you.
Second page.
And I will say I read through that this weekend and it helped me understand language and definitions. So I appreciate you sending that.
Could I ask you a question?
Yeah, hold on one second. So just so everyone has it, it's at the end of her testimony. And it might be something people want to read when they have time. All right, question.
What is the title of it?
I'm sorry.
What was the title?
It is Supporting and Caring for Transgender Children. Dr. Gibson, do you have time for questions?
I do. I have a little bit of time.
Okay, great. Art.
Just at the very end of your presentation, you said that anyone under 18 needs parental permission for medication. Okay, how about parental permission for any sort of counseling? Do they need it for that also?
For any sort of consult?
Yes.
Yes, for a medical consultation, they do. So a young person cannot just call and schedule to come to our clinic on their own, but there is coverage for confidential mental health care in state guidelines regarding gender identity for young people. So counseling can be accessed confidentially.
And that's something we passed in this committee a couple of years ago.
That's right. Yep.
Does that make sense, Art? Does that help you?
Doesn't make sense, but I understand it.
Okay. 2 different questions. All right.
I was just wondering, because it was the first thing that struck me. Are you comfortable with the language of gender dysphoria and gender incongruence? I mean, I know that actually dysphoria just was changed recently from disorder. And thinking about this being in statute forever and ever, is there?
Yeah, so yes, we've gone over this a little bit before, as the bills have moved forward. We do feel comfortable with the language of the newer language of gender incongruence, because not every young person is dysphoric. So it's more all encompassing.
Would you like to explain those two words for us?
So incongruence just refers to a mismatch, right? But dysphoria actually speaks to someone really being distressed and uncomfortable with that incongruence.
Thank you.
Sure.
Maureen?
Thank you for testifying today. In S37 on page 1, it refers to gender affirming healthcare services, supplies and care, but doesn't specifically mention medications. That's a concern to me. I wonder if you might have a similar concern. And just to be fair, Ledge Council is going to get back to us about whether or not the language actually does the statute include medications, but both for gender affirming care and reproductive care, it would seem like it would be stronger if it specifically mentioned medications.
I think that's a fair point to consider including that very specifically. You know, we in the medical world understand that gender affirming care includes the possible use of medication if a young person and family wants that, but it might not be so clearly understood to others. So you might need to state it very concretely. Fair point.
Thank you.
Mm-hmm.
Right.
So I have a question, but the thing is, like, on the floor of the House, we're not supposed to ask a question we know the answer to. But I'm a healthcare provider who does gender affirming care. But I just feel like something we're hearing from people is concerns about like the agenda of providers. And I wanted to ask you a question just to like dig into it a little, so you can maybe explain as a witness that, like, in gender affirming care, if a client comes to you and says, I don't want to feel this way, I want to change how I feel, how would a provider approach that? If the person says, like, I feel like my gender is incongruent, I want to feel differently, because and I say this in the context of like conversion therapy, which is banned, where the purpose is to help a person to change how they feel, but that's the only purpose. In gender affirming care, if a person came to you and said, I don't want to be like this, how would a provider approach that?
Tell me more.
That's what you would say, right?
That's what I would say. That's what I'd say. We need to be objective in this care. We are there to listen and to help a young person thrive. And we should not have any agenda either way, other than to help that young person live a happy, healthy life.
So it sounds like you would make space for the person to explore those feelings, lots of space and time, and let them figure it out.
Yeah, I mean, I think the main point of gender affirming care is we wouldn't just say, oh, that's wrong. What are you talking about? We need to change that for you. We would listen, acknowledge, discuss, provide resources, whatever they need.
I have a couple questions. Does anyone have any questions?
Yes, I got a tough question.
Go ahead.
If a child, minor, young, goes home, tells mom and dad, I want to change sexes, I do this, I'd like to know the protocol. And in your experience, because I'm very ignorant on this fact, does a child, 10, 11, realize they want to change sexes? And what's the research been done when they're 16 and 17 and 18?
So if a young person comes to a trusted adult like their parent, guardian, or anyone and says, I am questioning, my gender identity at this time, we would recommend that family seek some additional support around that question. Often in the vein of perhaps accessing some therapeutic support, whether it's individual therapy or family therapy. But it really depends to try to sort it out, especially if it's something that's new and different and concerning to a parent or guardian. And they also, like you're describing to me, aren't sure what this means or where to turn, because it does take some sort of ongoing conversation and sorting out, but it's different for every young person. There might be young people who have felt this way for a long time, but have never been able to actually articulate it. And there are other young, and so they might finally come forward and say, hey, I've been feeling this way since I was 4, but I didn't know how to put it into words or tell anyone, and I just want to sort it out. There might be other young people who say, hey, I just realized this last week and I'm starting to think about it and I want to talk about it. And so the next step wouldn't be to just make an appointment to see a doctor to get medicine. It would be to further explore what that young person's actually experiencing, feeling, and what they might need as a next step. And not all young people feel, need, or want to proceed with any medical interventions. It really differs. There's a wide spectrum of that. And tell me what else you want to know on that topic.
The data that we have of a young person, 12 to 14, having this transfer, and then 5 to 10 years down the road, has there been any data collected to say, oh, we made the right decision, or I didn't?
There is. We have a lot of really good emerging data on a lot of very specific topics, from whether someone has used a puberty blocker or a gender affirming hormone, or that their health and well-being improves, that if folks have been very depressed and potentially suicidal because of their lack of comfort and acceptance in their gender, does improve after these interventions.
Thank you.
You're welcome.
Dr. Gibson, how long is someone normally in your care? So, a family makes an appointment, a youth is questioning, and there seems like there's a lot of therapy. Do they stay under the care of a doctor for a while, for not very long?
So yes, once people come to see us, we see them as often as they need to be seen, depending what they've decided to move forward with. So some families might come to see us just for information and education about resources, or about what might be an option, further down the line. And they might say, thanks so much for this information. We'll let you know if we want to come back and see you again. Some say, thanks so much for this information. We're not ready to proceed with anything, but we'd love to come back and check in with you again. And in general, we try to check in with people every 3 to 5 months, regardless, if they want to continue to see us. And if someone has decided to start on any sort of medication, they definitely are coming to see us every 3 to 6 months, because we do very close lab monitoring, interviews about how things are going, that kind of thing. And then we are a youth program. So once someone reaches age 18 or thereabouts, we work on transition to a young adult gender care program, of which there are several providers in the state. And then we do what we call a warm transition in terms of helping them move on to adult care. And I should clarify that therapy isn't always required or recommended. It just depends on that young person's needs and wants also.
Thank you. Leslie?
Thank you so much, Dr. Gibson. I was just wondering if you have any data, like how many youth come to your clinic, and then if you have any pathways of how many do want, gender affirming, puberty blockers, how many go on to do different kinds of things or just get counseling or whatever.
I don't have any of that data collated in a super hard data collection way to report to you. I can tell you we probably see in our program, we've seen up to now, we're probably around the 250 mark total. There are other pediatric gender care providers in the state also. And we have definitely a handful of folks that see us and don't start anything, but just keep coming back to us. But most of those eventually do decide to start something, but may just take a little bit more time. And then others do proceed with a blocker or a gender affirming hormone if they want it and it fits their needs, right? There's no prescribed path for any one person. So it really depends. It varies what they might start on. I will say, I don't think many people come to see us that don't feel like they are truly considering potentially starting something eventually. So those folks who are just continuing to provide social support and aren't comfortable with any medical interventions yet aren't being referred or making appointments to come to our clinic. Does that answer your question?
Yeah, I'm just trying to understand the scope.
Mm-hmm. Any other questions for Dr. Gibson? Thank you so much for your time and your testimony. And as we continue taking testimony, I may reach out if there's more questions. So hopefully that's okay. But I appreciate your time.
Sounds good. Thank you so much for all your work and support. Okay.
Thank you.
Bye.
Bye-bye. All right. Now we have, I think, Polly, I'm going to try and say it right, Grozier. I'm so bad with last names. I'm sorry.
Do not apologize. My name is a conundrum for many people.
Okay, good.
Also because my parents named me Patience, but then immediately started calling me Polly. So I really respond to anything. So thank you for having me.
Thank you. And you're the senior staff attorney with GLBTQ Legal Advocates and Defenders, correct?
Well, yes, I've actually gotten a promotion. So now I'm the director of family advocacy, but yes, you've got my organization right at GLBTQ.
Congratulations. Congratulations. Well, great. Thank you for joining us. And I'm going to turn it over to you for your testimony, and then we may have some questions.
Sounds wonderful. Thank you so much for having me today. Yes, my name is Polly Crozier, and I'm the Director of Family Advocacy at GLAAD. I'll use the short name. GLAAD, as you all know, works in New England and nationally to promote justice on the basis of sexual orientation, gender identity and expression, and HIV status. And we've really had the pleasure of collaborating with Vermonters over decades for various freedom and justice work. And it's a pleasure to be here with this committee today. I'm testifying in strong support of S37. Through this bill, I think Vermont really rises to the challenge of not only the U.S. Supreme Court stripping away the longstanding right to abortion and bodily autonomy, and of course, the threats to really foundational rights to equal marriage and LGBTQ intimacy, but also to really the state legislative attacks across the country on the very humanity and existence of transgender people. I think this bill really signals to Vermonters and honestly to the entire country that Vermont is going to use its resources to ensure that Vermonters and Vermont providers and not the government are the ones making decisions about healthcare and well-being, to ensure that there's robust access to reproductive and gender affirming healthcare, and that patients and providers are protected as much as possible from attacks and efforts in other states to restrict and criminalize vital evidence-based healthcare. Because the goal is really to ensure that Vermonters and their providers can thrive in their lives and their livelihoods. I think this bill is incredibly important for the LGBTQ community. LGBTQ people, particularly transgender people, are facing truly unprecedented attacks across the country. Hundreds of bills have been filed attacking transgender people and their right to access to medical care, for youth to participate in sports, for youth to use accurate names and pronouns, for youth to use restrooms. I saw a bill in one state that I had to address last week, and youth and school trips. There's really an all-out assault on transgender people and really efforts to dehumanize them, strip them of their right to exist and thrive as the beloved community members and family members that we know them to be. We've been working very hard on defense in collaboration with many to try to hold back these efforts in New England states, because there have been many anti-trans bills in New Hampshire, Maine, Rhode Island, and in Connecticut. And just last Wednesday, I spent a very long night in Rhode Island opposing 4 anti-LGBTQ bills in a House committee. GLAAD has also been collaborating on court challenges to transgender medical care bans. As you know, Alabama enacted a ban that makes it a felony with a possible 10-year prison sentence for a provider or a parent or anyone who assists a young person in accessing medically necessary best practice gender affirming care. And GLAAD has filed a challenge to that law. It is currently enjoined in Alabama, and the trial on that bill will be about that law will be this summer in August. Just last week, my colleagues at GLAAD filed a lawsuit against the Florida ban on transgender healthcare that was issued by their Board of Medicine and Board of Osteopathic Medicine, and have already seen the impacts on children and their parents in Florida and care already being taken away in that state. I think that the pace of harmful bills in other states this session has been tremendously fast. Since I testified in the Senate committee about this bill less than 2 months ago, many more bans have passed. This year alone, 10 states have banned access to gender affirming care. I think this is just honestly an incredibly terrifying national context. And I'm grateful for the work of Vermont to try to insulate Vermont from attack and to try to, stand up for access in this state. I think this bill, we particularly appreciate protecting providers from disciplinary action, protecting their licenses, because for providers who are providing medically necessary evidence-based care, particularly in the realm of transgender healthcare, it's so important because there's so many different providers. It's such interdisciplinary, careful, thoughtful care. And it's so important to protect everybody who's involved in the provision of that care. I think the bill is wonderful to ensure insurance coverage for medically necessary transgender healthcare. Again, this is a very vulnerable group of people, and we need to make sure that they have access to medical care. I think it will better understand existing holes in access to transgender healthcare in Vermont. I just want to say we think the bill is a very positive step forward. I think that what other states have lost sight of is that transgender healthcare is well established. Standard of care medicine, 22, we heard Dr. Gibson and others talk about how 22 medical societies have show that this is, incredibly necessary care to treat the serious but treatable condition of gender dysphoria. And for the states who are banning this access to care, it's harming parents, it's harming children first and foremost, and it's driving providers away from practice in a way that I think really undermines access to healthcare, the entire healthcare system for everyone. I know that I do a lot of work throughout New England, and I've talked to providers, and I've talked to a provider who now wears a bulletproof vest on his way to his clinic. Another who has had to move homes. Another who works in a hospital that has gotten repeatedly shut down because of bomb threats, right? The emergency room of the biggest children's hospital in the state of Massachusetts. So I think these kinds of attacks in this kind of environment really, again, undermines our healthcare system. And whatever we can do to protect providers from attacks, to protect access to healthcare is incredibly important. So I think this is an exceptional moment in history. I'm grateful for your hard work thinking this through and making sure the law fits Vermont as best as possible, and for your vision to protect access to healthcare in your state. So thank you so much. Happy to answer questions.
Great. Thank you very much for your testimony. Does anyone have any questions? Leslie?
I have a question, but I'm not sure. Thank you for your testimony. I'm not sure where the answer is. So I'm just going to ask it. I really, support this bill, but I hear a lot about wraparound services and trying to understand how that would occur in a telehealth model in another state. So that, if you get my idea.
Holly, is that something?
I will defer to the doctors. I will just share, I'm happy to share just one impression I've had with a provider not in Vermont, but from a provider in Massachusetts who provides healthcare in a number of states, which is that I think for some providers, it's not unusual because, again, transgender healthcare, right? It lasts a long time, right? It's different from abortion in that way, right? You follow a patient and you support someone for a number of years, if not their whole life. And that for folks who, like, let's say you have a Vermonter who goes to college in Florida, right? And has some mix up with their medication and they need to call their pediatrician and say, oh goodness, you know, I'm having some issue with this medication. I can't get up to see you for another 3 months. And that provider is through telemedicine in Vermont, providing information to their Vermont patient who happens to be in college or on a school trip or whatnot in another state. I think that is a reasonable scenario where we would want to make sure that Vermont provider is protected. Obviously, you can't do anything about the child or the person in that other state, but you can certainly protect the provider who is located in Vermont and providing legal healthcare to a Vermonter who's traveling or in another state.
Thank you, Polly. And we'll have a doctor later in the week, Leslie, that if you want to jot that question down, we can ask them as well. Any other questions?
I had a question for Jessa, but.
She'll be back.
Okay.
Yep, she'll be back.
She's already
Well, let's work with Polly first, and then we'll turn back to Jessa, and then we'll go to Sharon. Yes, Sharon. So any other questions for Polly? Polly, I don't think you sent us written testimony. Can you jot down your support and send it in writing as well?
100%. I actually have it on my computer right at the moment. So when we're done here, I will send that in. So sorry.
Great. No worries. Thank you very much. And we appreciate your time.
All right. Thank you so much.
Thanks.
Good luck.
So do you want to come back up and we'll finish with you and then we'll go to Sharon and then we'll move on. All right.
Happy to answer questions.
Yep.
Sorry, I did miss the.
That's okay. So we'll go with Art and then Leslie, you can answer your questions again and then Mari.
And question, I just had a question on if another state that doesn't think the way we think tries a lawsuit or brings suit against a provider of these types of care, whether it's warranted or not, what does it cause to happen to the provider?
Well, great question. And that's exactly the type of scenario we're trying to address with these bills. And it.
Well, okay, say the bill, if the bill is approved, what would happen? Does it just get dismissed and the doctor never knows about it?
Excuse me, I'm sorry.
Or does the doctor know about it, have to provide information? You know, what impact does just the suit?
So let me just clarify that S37 is less about lawsuits than disciplinary action. So it would not necessarily be a lawsuit filed. That's addressed by H89. But in S37, it would be a state licensing board from another state filing there would be an administrative complaint.
Okay.
So a patient, family member, bystander, person on the street who hears about services provided would file a complaint with the licensing board in whichever state, Texas, Alabama, Louisiana. And then
we're gonna stop 1 minute. Hold on. I want you to take a moment.
Sorry. Thank you. So that then typically what happens in a licensing complaint is that provider would be notified that a complaint had been filed. And the boards, and you'll have OPR and the Board of Medical Practice here too. So if you really want the real details, they could walk you through, but that provider has to respond. And then if just based on that response, sometimes the board could dismiss the complaint, but otherwise it could proceed to sort of an administrative hearing.
Is this now assuming 37 is approved?
With what S37 does, what S37 changes is all of that could still proceed in Texas, Louisiana, whatever state. That action could still go forward.
Okay.
And the question is, so say say we're talking about, let's take Florida, because Florida, we now know, has rules saying that providing gender affirming care is unprofessional conduct. And say nothing was substandard about the care provided. It was
Sure,
just providing
right,
gender
right.
affirming care.
That's just what I want to get.
That's all that happened. And that provider is either located in Vermont and did it via telemedicine, or maybe even the patient traveled to Vermont, but then went back home to Florida. And now somebody's upset that this care happened and this complaint's proceeding, this disciplinary action is proceeding in Florida. So, and then Florida would have to find that this was unprofessional conduct because now their rules say it is. The question is, does Vermont's licensing boards say, whether if it's an MD or a physician assistant, it would be the Board of Medical Practice. If it was a nurse practitioner or nurse or counselor, it would be under Office of Professional Regulation. Do they have to say, because you were disciplined in that state, we now have to investigate, or we have to find that you also engaged in unprofessional, if another state finds that you engaged in unprofessional conduct, often that currently triggers an automatic investigation in Vermont as well. And again, the boards could sort of give you more of the nuanced details of that. But what we're saying is no, Vermont doesn't have to automatically take action or investigate if this is just because the Florida Board of Medical Practice found that you engaged in unprofessional conduct.
Okay.
If they found it was unprofessional conduct because of some other reason, like it wasn't up to the standard of care, you violated some other law, you defrauded the patient, you lied to the patient, you know, whatever it may be, some other reason why it was unprofessional conduct, that investigation could still, or discipline could still take place in Vermont. So we're not trying to prevent the board from disciplining you if you really did not, you know, there was some other reason why you violated the standard.
Okay, well, what I'm trying to get at is no matter what the complaint from some of the state is, there is upset to the physician, even with 37.
Yes, there's a limit to what Vermont can do to protect our providers from action in other states.
I mean,
right?
they'd
Yes.
be protected if they did everything right. They did everything according to Hoyle, everything was done properly.
Yes.
But a state filed what you said.
Yes.
They're still going to have to justify what they did. So a physician, while he'll be found innocent, he doesn't have to worry necessarily. He or she still would have to go through the machinations of.
In Florida. Correct. What we're trying to say is you don't also then have to do that in Vermont. Because we can't tell the Florida Board of Licensure, don't discipline, don't investigate. But what we can say is just because the Vermont boards are now notified that this complaint happened or this investigation happened, you don't subject this Vermont provider to that same process here in Vermont because of that.
Okay, so a Vermont provider wouldn't have to go through that.
Correct. For their Vermont board.
Vermont license.
But they would have their Vermont license.
Okay, but they might have to.
They might
for
in the other
state license.
Correct.
So if they stop your license, then you can't do anything in that state.
Correct. So if you were licensed in Florida, they could remove your Florida license for doing that. What the twist to this whole scenario is what S37 is saying is you actually don't have to be licensed in Florida to practice telemedicine. So, however, again, I sort of started saying this in my earlier testimony, that's still not a perfect solution because then you could be disciplined for practicing without a license.
Okay, so.
By Florida.
Okay, so, all right, you don't have a Florida license, you do something with a Florida person.
Right.
They complain about it.
Right.
What happens to the patient? What upset happens to the patient, to the provider? Does the provider now have to give up all the records, respond to the license board in Vermont?
What we're trying to say is not in Vermont, but they may in Florida.
All right.
Because we can only control our own agency.
Okay, all right.
So we're trying to help as much as we can.
Okay, but there's still going to be, even with 37, there will still be upset to the provider of Vermont of some kind as far as they'll be notified of a complaint, potentially have to provide documentation as to what they did. So even though they don't have to worry about having a license pulled if they did everything right, they still have to respond
To the other state.
To the other state,
to the other state.
right?
Right, okay, so that still is going to happen if there's complaints from other states. But technically, if you did everything right, it won't hurt you financially or.
It won't hurt your Vermont
License
license, so you
wise.
could still practice in Vermont. You could retain
Gotcha,
your
all right,
Vermont
all right.
license,
So
still
it
practice
allows
in
you to
Vermont.
continue to practice in Vermont. Okay, I
Correct.
get it a little bit. Yeah, thank you.
And as Jessica said, we'll have OPR and Board of Medical.
All right.
So we can ask the question again.
Good.
And they can correct me if I got anything wrong.
Leslie, and then Mark, did you have a question?
Well, it was only about that vulnerable wraparound services, and I don't know if this is.
Let's wait for the doctor later in the week. That'd be great. Mari?
I'm going to ask my medication question to you too, but partly because you were involved on the Senate side. I don't know if you heard any discussion on that side, but.
I think it's a good question. I think, like Legislative Council said, I don't think anyone raised the question. So I certainly have I think it's a good idea. If it's not clear elsewhere in statute that it would be included, I'm fully in support of clarifying that.
Okay, thanks.
Melanie?
My question was along the lines, I just wanted to understand more about the professional licensing complaints. And so, but if I think you answered it. I think I'm good with that.
Any other questions for Jessa? Leslie?
I'm not sure that you know this question, but I'm just wondering the vulnerability of the clinician if they leave the state and it's considered a criminal act. Or
so again, criminal issues are addressed in H89, but yes, I think there is, depending on the risks you are kind of willing to take in your professional conduct. I've already heard from members of ours and physicians in other states who are concerned about traveling to various states currently, even not with an outstanding criminal issue, but just knowing what services they provide and what that actions could be taken in those states. So it's a real, the legislation these states are passing is effective. Mm-hmm. It's effective at banning services, making people fearful, even in states where certain exceptions are allowed, it's created such a culture of fear that providers are no longer providing them or leaving those states. You probably saw the article not too long ago about an Idaho hospital no longer providing any maternity services because all of their OB-GYNs have left. Mm-hmm. So it's creating real fear of licensing repercussions, criminal, civil penalties. So yes. I think travel medical organizations are considering what state to hold their conferences in because providers aren't comfortable traveling to certain states and knowing they would be there for an extended period of time. So, yeah.
I don't know if it's for now, but I'm just curious how this is playing out with like the licensing and the training of new medical doctors coming in.
It is having significant implications for medical training because there are residency training programs in certain states where procedures are now illegal. And so it's a big topic of discussion. Will those residency programs be able to make sure people can do rotations in states where they are allowed to provide them? Will they stop providing certain types of training? And then there'll be a whole generation of providers who can't provide certain types of services. And I think there's sometimes this, we don't necessarily have as much of this conversation in Vermont, but I've heard a lot from my colleagues around the country about extremely medically necessary examples of providing abortion. Women in late pregnancy having miscarriages that need help managing that miscarriage. These are not what we might think of as sort of voluntary procedures. And so OB-GYNs, emergency department physicians need to be trained in these procedures. And if you can't, we are going to have women, pregnant people, their health and safety is really going to be at risk around the country now.
All right, any other questions?
Yeah, thank you. That's important.
Great, thank you. And I apologize, we interrupted.
Oh, no problem.
Money. I appreciate you working with us.
Thank you for having me.
Sharon, and I apologize you've been waiting so long. Come on up. So Sharon, is it Toberg?
Yes, it is.
Great.
Although it's with 2 O's, not a U.
Oh, 2 O's. Okay, great. That in there. Welcome.
Thank you. Thank you for the opportunity to be here today. My name is Sharon Toborg. I'm the policy analyst for the Vermont Right to Life Committee, and I'm glad to address some concerns we have with S37. Obviously, we have a lot of concerns with it, but some of them we know are nothing that we can do about in this committee. So we'll just address some of the things that we hope you will take under consideration.
Great.
First of all, our first concern is that S37 establishes in law lower standards for providers of so-called legally protected healthcare than for providers of other types of care. We've talked a lot about the definition of legally protected healthcare, noting that it allows a healthcare provider in the state of Vermont, located in Vermont, to provide care through telehealth to a patient that is in another state, physically located there, without necessarily getting a license to do so. Now, this actually conflicts with the Vermont Board of Medical Practices recently adopted policy on the appropriate use of telemedicine technologies and practices in medicine, which states that the state of Vermont and the board follow the rule on medical licensure recognized across the United States. A physician must be licensed or appropriately authorized by the medical board of the state where the patient is located. The practice of medicine occurs where the patient is located at the time that telemedicine technologies are used. Physicians who diagnose, treat, or prescribe using online service sites are engaging in the practice of medicine and must possess appropriate licensure in the jurisdiction where the patient receives care. Now, currently, under Vermont law, practicing medicine in a state without being properly licensed in that state constitutes unprofessional conduct. And that's why S37 proposes to carve out an exception to that standard for providers of so-called legally protected healthcare. Under S37, what would constitute unprofessional conduct for other healthcare providers would be allowable for providers of so-called legally protected healthcare. This lowering of the standard is very concerning to us, and it sets a dangerous precedent of loosening standards for those providing politically favored services. As S37 acknowledges, this new standard allowing practitioners to practice in other states without being properly licensed is less protective of the public, but would still be allowed. And I think we also have to be cognizant of the fact that our new constitutional amendment, Article 22, allows regulation of healthcare when it is, there is a compelling state interest. But in acknowledging that providers of healthcare, reproductive healthcare, do not have to meet those standards, this body will lessen the ability of the state of Vermont in the future to present an argument that meets a compelling state interest standard. And ironically, Vermont requires healthcare providers who treat patients located in Vermont to have appropriate licensing or approval, and will fine them or otherwise sanction them if they do not. And Vermont should not protect healthcare providers who treat patients in other states without proper licensing in violation of those states' laws. Second, S37 unfairly and unconstitutionally targets pregnancy centers. Section 8 of S37 unfairly and unconstitutionally targets pregnancy centers for their efforts to aid women facing unintended pregnancies. And that section should be stricken from the bill. VRLC also takes issue with the findings of the General Assembly that imply that pregnancy centers provide confusing, misleading, or inaccurate information. Testimony in the Senate indicated that no complaints have been filed against the pregnancy centers, and the centers get high marks from clients in satisfaction surveys. Section 8 pays lip service to the First Amendment rights of pregnancy centers while allowing the Attorney General broad authority to establish rules, conduct investigations, and bring civil actions against them. This will have a chilling effect on the center's speech, particularly since Vermont's current Attorney General has been openly hostile towards them. And including this section, it will invite expensive and time-consuming litigation. Further, if the state were truly concerned about unfair, deceptive, or misleading information and actions, then all providers of similar services should be subject to the same regulations. The state should be particularly concerned that a person or a patient might receive insufficient or misleading information about abortion because that is a decision that cannot be reversed. A woman can change her mind about carrying a pregnancy to term if she receives new information. While most pregnancy centers in Vermont have their own medical director, Planned Parenthood of Northern New England currently does not. The PPNNE has an interim clinic director who is not an MD, who oversees 17 clinics in 3 states, Maine, New Hampshire, and Vermont. In addition, PPNNE employs non-physicians to perform surgical abortions and medication abortions. PPNNE also recruits and trains volunteers, including kids as young as 14 years old, to serve as volunteer sexual health educators for their peers. If a pregnancy center medical director is to be held legally responsible and professionally responsible for the activities of the staff and volunteers as proposed in S37, why shouldn't Planned Parenthood's director be as well? Third, we believe S37 should provide at least as much support for carrying a pregnancy to term as it does for abortion. In Senate testimony, Vermont Right to Life expressed concern that the bill, as introduced, required UVM and the Vermont colleges to develop an abortion services readiness plan rather than an abortion and pregnancy services readiness plan. The Senate subsequently changed the language of the bill from abortion service readiness to reproductive health care readiness. VRLC encourages this committee to include in section 2502, which is the section detailing what must be included in the report that the colleges submit for their readiness plan, to include a provision that UVM and the Vermont State Colleges include in their required gender-affirming healthcare and reproductive healthcare readiness reports information about the institution's efforts to assist pregnant and parenting students who are trying to complete their degree. The University of Vermont has made some provisions under the requirements of Title IX, which prevents discrimination against pregnant and parenting students, but much more can and should be done at both UVM and the Vermont State Colleges. For example, the University of Massachusetts at Amherst has a website geared specifically for student parents that opens with, "Welcome student parents. Are you pregnant or parenting student? Student Parent Programs is here for you." And then similarly, under the insurance coverage section of S37, if the state is going to eliminate co-pays and co-insurance for abortion, co-pays for prenatal care and childbirth should be eliminated as well. That was my prepared testimony, but I would like to address some of the comments and questions that we've heard. Representative DeMar, I believe you asked about a child who uses insurance to get an abortion. In Vermont, parents are not entitled to the insurance information of a child once the child reaches 12 years old, and that information can be kept confidential. And as you noted, Representative Peterson, this is about not just providing out-of-state care without a license to Vermont residents. It can apply to any person in any state. I'd be happy to answer any questions that
Great,
I have.
thank you. Do we have any questions?
Could you clarify what you just said regarding over the age of 12 confidential medical information?
You're not entitled to the health insurance information of your child if they're over 12 without their permission.
You receive an explanation of benefits on every single service.
Not if your child goes online, creates an online account and says you do not receive it.
Who would they be creating that online account with?
With the insurance company.
So we'll check with the
insurance.
I have heard something about this before, so we should
And
take more
making a note.
testimony. Yeah, I have heard something like this.
If I log into my health insurance account, I cannot see any of my child's claims once they turn 12.
We'll check into that. I know I can.
Well, let me clarify. I mean, you can, but if the child were to take initiative to prevent that.
I've even heard, just for what it's worth, I have heard from, I'm a healthcare provider, I've heard from parents that they have called the insurance company to ask a question about me getting paid for the kid, and there's been issues with them talking with the parents until the kid gets on the phone. But I don't remember the details, which is why we need testimony, but I have heard at least once of this happening. So.
Any other questions? Jim, can we get a copy of your testimony?
Yes.
Or when you have a second?
Email it over.
Perfect, great. Thank you so much. And again, thank you for being here today and waiting as long as you did.
Thank you very much.
Well, thank you.
Thank you. All right, like I said before, we're gonna now, this was kind of like the overview of everything. We're gonna, over the next week, the agenda's posted, we're gonna do things by sections, try and keep like things together as we move through this. I've made some notes, and maybe you all have some questions, and then at some point we'll have Amber walk through the findings again, or Jen. So we're far from over on testimony. We'll be doing this all week and into next week as well. Let's take does everyone, we probably should have a break. Let's take a break till 4:15. Jen, are you okay? And then we're gonna come back at 4:15 and look at the amendment on